Are we ready to get into Sepsis 2013? Woo! Oh, I like it. I like the enthusiasm, considering this is sort of like that pre-lunch lull where typically everybody's like half asleep, present company included. So Sepsis 2013. Now, with sepsis, there's a lot to talk about, and this particular chapter talks about a lot of different aspects of sepsis, caring for the septic patients, some biomarkers. It really talks about a lot of interesting concepts, and I think people will have something to say about a lot of these issues. But here's the way I sort of see sepsis generally. If we look at the bigger picture of things, it seems to me like, at some point in time, we sort of had the dawn of civilization. And then there was the development of medicine. And then there was this theory that bacteria cause disease. And then we had sort of tests to test for those things, and it seemed like life was pretty simple. I didn't really practice very much in this era. This is a little before my time, but it was like, you had pneumonia. You had a guess of what the bug was that caused it. You gave an antibiotic for that, and you were kind of done. And then in 2001, everything we knew about sepsis changed because apparently we were doing everything wrong prior to that. And this is the development of the Surviving Sepsis campaign in the Manny Rivers paper, right? And we all know about this thing, right? And does this impact our daily lives in the emergency department? Absolutely it does. And what does it say generally? I mean, it's easy enough to summarize. We're checking CVPs on these patients, and we need to get their CVP above 8. We're checking MAPs. We need to get those above 65 using pressors. And then we're checking their central venous oxygen saturation, and we want that to be higher than 70, and we're using packed red blood cells to do that for the most part, getting their hemoglobin above 30. So this thing, when it got developed, it got rapidly endorsed by clinicians, by JCO. Everybody really latched onto this thing. And what's interesting about it is they say if you follow the tenets of the Surviving Sepsis campaign, it's like everything magically gets better. Hospital length of stay goes down by half. Costs go down by $7,000 per patient. What else do they say here? Mortality decreases by, what did they say in the original study? 46%, if you just follow these few simple rules. So the first section, the first question, it's called do order sets or protocols actually work when implemented in septic patients? But that's not really what this section's about if you look at these abstracts that are in here. What it really is kind of a potpourri of different things to talk about in sepsis. And the first one is nothing more than an editorial piece. It's an editorial piece, and I love the title. Early Goal-Directed Therapy on Terminal Life Support. Right? So this author of this paper is of the belief that most of the things that are proposed in early goal-directed therapy really have no strong evidence behind them, and they don't work as well as we are made to believe. And I think the strongest piece of evidence he gives here is he says that according to the River study and the early goal-directed therapy protocol, the number needed to treat, so the number of patients you need to treat to save a life is 6. Right? This is way too low of a number. Antibiotics aren't even close to this range of 6 if you were to give antibiotics. So this is just, it's too good to be true, is basically what he's saying. And I think that's probably right. We adopted it way too quickly, but just so you know, there is a very large multi-center study going on right now called the Process Trial, which we don't have even preliminary results of yet, which is evaluating the Rivers protocol in great detail, looking at the different components to see if this stuff actually works. I think we all know from our clinical practice that it's not going to work as well as that first paper said it did. There's no question about that. The next one looks at compliance with early goal-directed therapy, and I like this one a lot. So this is a study from UPenn, and basically in 2005, this is their way of, do most people have like sort of sepsis protocol sheets, like order sheets now that just sort of automatically pop up with the right antibiotics and the right fluids and what to do and stuff. So what they did here is one better than that. At UPenn in 2005, they said, boy, this thing is important. If we do this right, we have half our length of stay, we decrease our costs. So let's establish a 24/7 available early goal-directed therapy team. So this is a team of physicians and nurses where if you were in the ED and you diagnosed the patient with sepsis, 24/7, you could just wipe your hands and be done. Call this pager number, and a team of individuals would come down and implement this early goal-directed therapy to the T, right? That was sort of the theory behind what was going to happen here. And what did they find? Early goal-directed therapy was implemented in its fullness in about 40% of the patients, even with a team dedicated to just do this very thing. And when they looked at the mortality of the patients who got it versus who didn't get it, it was exactly the same. Mortality didn't change, even with a team of dedicated individuals doing exactly this thing. Now, granted, they had sort of a weird gold standard of who really got the full early goal-directed therapy, but I think the message is right. Is that even if you put a ton of time and a ton of money into this protocol, just following the protocol sort of word by word is not going to decrease your mortality by 50%. And those of you who thought it was, it isn't. I hate to be the bearer of bad news here, but there is no Santa Claus. The next abstract looks at compliance with a modified protocol. So they said, okay, well, this protocol is a little bit cumbersome to follow, and one of the most cumbersome parts is this continuous central venous O2 monitoring. So what if we sort of did spot monitoring instead? Does that have any impact on compliance? And what they found was that it didn't really have that much of an impact on compliance. It had no change in mortality. Again, we're seeing the same message over and over again. Again, like I said, this section is kind of a potpourri. So this next abstract asks a really different question, but a great clinical question. It has nothing to do with early goal-directed therapy, but does have something to do with sepsis. So etiology of illness in patients with severe sepsis admitted to the hospital from the emergency department. The clinical question here is, we see a patient. We admit them with the diagnosis of sepsis. What they did was they followed these patients out to discharge and said, okay, at hospital discharge, what percentage of these patients actually had sepsis? They had something grow positive. They had a blood culture grow positive. They had a pneumonia that popped up on their chest x-ray. They had a urine culture that grew positive. And what do you think they found? So these are all 200 patients that we said had sepsis. What percentage of the time do they actually have sepsis? Are we good, horrible? How'd we do? So about 1 out of 5 patients had everything come back completely negative. So we called them sepsis, we admitted them for sepsis, we may have even started early goal-directed therapy, but they did not have sepsis. They did not have a bacterial infection. So what is the point of this abstract? The point of this, just so you know, they look at a lot of other things, like, okay, well, how could we have done this a little better? Let's look at lactate levels, let's look at white blood cell counts, let's look at temperature, let's look at heart rate, and they were all the same between the two groups, between the group that eventually ended up having sepsis and those that did not. So the take-home message here is just to remember that just because it looks like sepsis and smells like sepsis, sometimes it's not sepsis. There are a lot of other things that can cause a similar constellation of clinical symptoms, with salicylate toxicity being high on the list. So just remember that we're sort of eager when we see a sepsis patient, just pull the trigger and go, sepsis, boom, done, got it, put them on this protocol, walk away from the patient, that there are mimics that look like sepsis, and I think this paper is a good reminder of that. And the last paper in this section attempts, sort of poorly, to look at the impact of a protocol. And this is basically a pre and post study where they look at 200 patients before the institution of a protocol to manage septic patients and after. And what they found was essentially things didn't do much better. Their conclusion is they say they did better, but they got better IV fluids. So after the protocol, in total, in their stay in the emergency department, these septic patients got 2 liters of fluids. And before the protocol, it was 1,700 cc's. So what do we think about that? The difference, non-significant, but even more importantly, this is a sucky resuscitation in general, right? If these are really septic patients, giving them 700 cc's in their whole ED stay is completely ridiculous. Shorter time to antibiotics, well, that's good. Right, so the group after the intervention, after the protocol, but a shorter time to antibiotic. Whew, thank God. Thank God it went from 16 hours down to 12 hours. That's right. It's on average, but that's what happened. That's not that impressive in my book. Mortality just about the same. I don't want to totally dismiss the tenets of early goal-directed therapy because I think that at its heart, it actually is very good. Early antibiotics, correct antibiotics, good, strong fluid resuscitation. Give these patients blood if they need blood. I like it generally. I just sort of want to say that following the just check this, is not going to make any difference. You really do have to sort of, I think, individualize your treatment to the patient in front of you, but certainly being aggressive with these septic patients is a very, very good thing. Okay, I like the next question. How about lactate levels? Why am I getting them so much more now than I was in the past? And sometimes they just don't make sense. So how many people are sending lactate levels in their emergency department? Yeah, just about everybody. Who are we sending them on? Just about everybody. That's what it feels like to me too. It seems like anybody who comes in, it's like, okay, you look sort of sick. I'm going to get a lactate level. Why are you getting it? I don't know exactly, but I do. I get it on all these patients now. And there are some good reasons to it, I guess. One is that officially in early goal-directed therapy, following the trend of the lactate levels can now replace the need for the central venous oxygen measurement. Right? So that's probably the biggest reason to get in a septic patient. So putting in the Edwards catheter and hooking it up to the monitor and all the training that needs to be done with that can now be replaced by following lactate levels. So that's the reason why we get in a septic patient. That I understand. Why we get in everybody else, I'm just as guilty as you are, not exactly sure. I'm not exactly sure how it helps me, and I agree that it is sort of confusing. And in fact, it's so confusing as to how unhelpful, I'll say it is, if you look at abstract number 6. So they look at base excess, right? They basically take a group of patients who are sick patients, and they were likely sepsis, is what they were called, and they all got lactate levels, and they all got a base excess calculated. And for what a base excess is essentially is how much acid would you have to sort of add to the blood to get it back to a normal pH of 7.4. So this is a very infrequently used test, base excess, and they said, okay, which one's better at predicting sepsis and predicting how these patients are going to do? Lactate, which is what we all send all the time, or this essentially totally random base excess test. And what do they find? They're both about the same. Right? Both did almost the same in terms of determining who is eventually going to have sepsis, who is going to be sick. So the real question here is that, are either of these two tests just better than our own clinical judgment, our own clinical gestalt? And the answer is probably no. Abstract number 7 focuses just on point-of-care lactate. So how many people are using point-of-care lactate in the emergency department? So just a small handful, and just so you know, point-of-care lactate does correlate very well with the serum lactate that goes to the lab. That's all this study is saying. They're just taking a group of patients, and they had serum lactates, and they had the point-of-care lactates, and they looked at the numbers, and they all seem to correlate well. So if you're going to use a lactate, and you want to convert to a point-of-care lactate, and generally I'm very much in favor of doing point-of-care testing in the emergency department, point-of-care lactate is an okay test to do. Okay, next question. Can we identify patients in the emergency department who have a bacterial source of sepsis? So what do we think? Is there a good, reliable clinical way? Is there some really awesome laboratory test that you've never heard of that tells you immediately if they have bacterial sepsis? How about some imaging test? Like a magic wand or something like that. So the answer is obviously no. And it just goes through a series of things telling us why our lives are so difficult every day. So abstract number 8, the inadequacy of temperature and white blood cell count in predicting bacteremia in patients with suspected infection. I think this is pretty self-explanatory. This is a post hoc analysis of almost 250 or 300 patients. And what they found here was that the sensitivity of white blood cell count for patients, elevated white blood cell count for patients with a bacterial source of infection was 48%. So just slightly worse than flipping a coin, not much, but just slightly. And then the sensitivity of temperature was 67%. So about 2/3 sensitive. Remembering the fact that sometimes the most septic and most sick patients are actually hypothermic, right? So they were looking at elevations in temperature here. And just so you know, it's important to know that in this particular study, these are all patients, all 200 and however many there were, 289 patients who had positive blood cultures. So these were patients who were truly septic, and the white blood cell count was still only helpful in half the cases, or you could say it was unhelpful in half the cases, depending on how you want to interpret that same data. And then how about UA and chest x-ray? That's what abstract number 9 deals with. And they give a sensitivity of the urinalysis, initial urinalysis of 80%, and the specificity of 75%. And chest x-ray, they basically said pneumonia was a final diagnosis in 85 of patients in this study, and 36 of them, so almost half, had negative initial chest x-rays. So I know this is a bit of a depressing section, saying lab tests and imaging tests we have aren't as helpful as we'd like them to be, but that's the reality of it, you know? And I think it sends home a really important message, which is that in sick, septic, shocky patients, our tests aren't as reliable as we'd like them to be. Our imaging studies aren't as reliable as we'd like them to be. There is no perfect way to know what infection, what the source is, what type of bug it's going to be. So I think the take-home message here is it's okay and probably encouraged to be broad with your antibiotic coverage initially until we can take some time and tease out exactly what's going on with the patient. So broad antibiotic coverage seems highly appropriate to me in these sick, what we think are septic, shocky patients. And abstract number 10 is basically a chart review, and this is another really important point too, and they're just looking at our kind of our hit rate with our antibiotic choices. So there's 140 patients admitted to the ICU with a diagnosis of sepsis, almost all of them caused by pneumonia and urinary tract infections, and they said, okay, now looking back, we have the blood cultures, we have the retrospectoscope, we get to see exactly how well the ED docs did in terms of choosing their coverage, and what they found was that our coverage was adequate to cover the bugs about 80% of the time. So 20% of the time we were giving antibiotics that weren't working in the emergency department. Now, why is this? We weren't broad enough, and they went on further to say that if we had just used, in this particular case, every hospital has one, right? Like sort of, you have sepsis, you should probably get this. You were recently in a hospital, you should add this thing on. You came from a nursing home, let's tack on one more antibiotic. If we had just followed those guidelines, we would have had a 100% hit rate. And I think it's really good to do that, to know what our antibiotic are at our specific hospitals and what they suggest we cover with things, because they're typically on the money. And if you work at multiple hospitals, know that what works at one hospital may not work at the other hospital, even if that hospital is just across the street. Right, so these are not things that vary like from state to state or county to county. They really do vary from hospital to hospital. And the reason for that has to do with the prescribing patterns and antibiotic usage of that particular hospital. That tends to dictate sort of what you give and what things are resistant to based out of that hospital. Really important. Okay, next question. I like how it is worded. What is this week's dogma as to whether steroids should be utilized? So who uses steroids in septic patients? Nobody. Well, maybe we can just skip this section altogether then. That's good. There's a few randomized controlled trials here. The first one is in cirrhotic patients. So just kind of thinking, okay, you're septic, you're cirrhotic. If anybody needs steroids on this earth, it's going to be you, buddy. So that's why they sort of chose this cohort. I like it. It's a small RCT. There were only 50 patients, and they gave them hydrocortisone, half of them, and the other group didn't. And the group that got hydrocortisone actually did a little bit worse than the group that didn't get any hydrocortisone. So most studies on this issue sort of show equivalence between the two groups, and this is a rare study that actually shows that they got a little bit worse if they got some steroids. But then a much larger look at abstract number 13. This is data from the Surviving Sepsis campaign. So this is like 18,000 patients, it's like bajillions of patients. And they found essentially that this wasn't an RCT. They just sort of looked at practice patterns, and they saw that there was no big difference in mortality if you got steroids or not. In fact, the group that got steroids did just a little bit worse than the group that didn't. All right, so next question. I like this question quite a bit. Surely the issue of whether it is okay to use etomidate has been settled by now. All right? So the question of what is the issue with etomidate? At least the theoretical issue? adrenal suppression, right? So this started back in the 1980s where there were a series of letters published in Lancet that said, hey, we've sort of noticed that we've started giving etomidate to patients here, and the patients who get RSI in the emergency department and you etomidate to get it seem to do a little bit worse than those who don't. We don't know why at this point, but we just want to sort of put it out there for the medical people, the researchers, people want to get in there and figure it out. But these are just a series of letters saying we have noticed this at a series of hospitals. Now, just so you know, there are lots of studies that show that if you give one dose of etomidate, you will very transiently suppress adrenal function. That is a fact. Right? We know that to be true. And that's what sort of starts the controversy and what we were sort of starting to talk about in the panel, and you hear a lot if you've ever heard one tape before coming to this conference, you will know that we love to focus on disease-oriented outcomes versus patient-oriented outcomes, right? So we know that etomidate actually has a negative effect on a disease-oriented outcome. You have a very transient drop in your adrenal function. But does this matter? That's really the question. Abstract number 14 is just a pro and con piece. I don't really think it's all that important. The next three are actually trials. So abstract 15 is a prospective observational study of the effect of etomidate on septic patient mortality and length of stay, and it's done by a Dr. Tekwani, who actually does a lot of work in this area. This is a prospective cohort of 100 patients, and they found that mortality, when they looked if you got etomidate versus non-etomidate in septic patients, was essentially the same. Abstract number 16 is a randomized double-blind controlled trial of 122 patients by the same guy, Dr. Tekwani. These are patients who were intubated in the ED with sepsis, and they were randomized to get either etomidate or midazolam for their intubation, and they found ICU length of stay and overall length of stay to be slightly less in the etomidate group than in the midazolam group. So this is building on the body of literature that you don't need to worry about this adrenal suppression with etomidate. And the last one here is corticosteroids after etomidate in critically ill patients. So basically what they did here was they said, okay, we're just going to randomize them to, we're going to give them etomidate, and we're either going to give them a dose of hydrocortisone or we're not. And what they found, again, like we said, the cosintropin stim test was affected in the group that didn't get the hydrocortisone, but every patient-oriented outcome they looked at, mortality, length of stay, multi-system organ failure, time on the vent, et cetera, all the same whether they got this single dose of hydrocortisone or not. So take home from this section, I think, is that we don't need to worry about etomidate in septic patients. It's fine. It's okay. Just go ahead and use it, especially if that's what we're most comfortable with RSI. And the last question is, what's the latest on pressors? Is it even possible that after 70 plus years, we still don't know what pressor is best, or even whether pressors actually improve patient outcomes at all? Is that actually possible? Yes, it's not only possible, but it's true. So those of you who believe very strongly in surviving sepsis, well, they say you need either norepi and or dopamine, but most of the literature says, I don't know, man. It's kind of whatever you're most comfortable with. Use dopamine, use dopamine. You want to use norepinephrine, use norepinephrine. You want to use dobutamine, go ahead, have some fun with dobutamine. But the real question is whether any of these things are better. Not only are they better than each other, but do they do anything overall? And I can't really tell you. There's only one abstract here. It's a non-randomized trial looking at 900 adults, 50% of whom had septic shock, and they found that the norepinephrine group, which is what's suggested in the Surviving Sepsis campaign, actually had a slightly higher mortality than other pressors, so the dopamines and dobutamines of the world. And this is a non-randomized trial, so I don't really know what to make of this, because maybe the ones who got norepi were much sicker to begin with. They don't really give you those stats, unfortunately. But I would say the take-home message is, I actually don't know what the best pressor is, so I would just use the one that you're the most comfortable with, and you're the most comfortable with dosing, and if it doesn't seem to be working on this particular patient, hey, add another one, or just switch to another one. I'm not really sure what to say, but know that there is no correct answer. So you won't be faulted, if you want to look at it from a glass half full kind of perspective, you won't be faulted for choosing one pressor over another in a patient, because there is no evidence to show that there is a correct pressor. And we sort of end this chapter with, if you guys want to take your afternoon instead of sitting outside in the sun and actually read all these surviving sepsis recommendations, go ahead and do that. I've sort of summarized some of the most critical ones here. They list everything. And just so you know, whenever they give recommendations in a format like this, they give a sort of a grade of strength of evidence. So how strong is the evidence for the recommendations that we're making? And just so you know, a lot of the surviving sepsis recommendations are evidence level 2C or below, which means very little actual scientific evidence to support these things. But some of the critical points: be aggressive with fluids. If the patient can tolerate it, start with a minimum of 2 liters of fluids. They like norepi over dopamine, although they admit that there's really no evidence for this. If there's evidence of heart failure, they like dobutamine. They have finally said, okay, hydrocortisone, unnecessary here, unless the patient is failing to respond to fluids, failing to respond to pressors, they're going to die on you. Okay, fine, maybe throw some steroids at them, perhaps it'll do something, probably not. And then what I already mentioned before, which is the most important thing, which is new, which is now we can follow the trend of lactate levels instead of central venous O2 monitoring, which is really, really nice. I think in terms of 2013 sepsis, that's all I really want to say, unless there's any questions. Question?
So you had mentioned that the pressors have no benefit over nothing at all. Has anyone ever done that study?
Yes. So question was, has there ever been a study done that a pressor versus no pressor at all really has any benefit? There are studies. The evidence is weak because it's hard to get something like that through an IRB. You know, we're just going to let this guy sit at a blood pressure of 70 for a really long time. But it seems like, I think the people who are, like Jerry is the person who argues this the most eloquently. And I think that the argument generally is that if we can't find any one pressor that's better than any other pressor, and mortality doesn't seem to change versus when we just had either no pressor or one kind of pressor, how can we really say that pressors at all do anything good? Now, I will say that I personally I can't sit with that. I can't sit with a patient with a blood pressure of 60 in my emergency department. I can't do it. I feel obligated to put them on a pressor. I certainly have never read a paper that said putting them on a pressor does some harm over versus no pressor. So I think that there's a small potential that it works. To me, it logistically makes sense. If you try to call your ICU doc to admit a patient, say, hey, I have a blood pressure down here of 50. Whoa, what'd you do for him? Not much, just kind of watching him, gave him a little bit of fluids, hoping for the best, fingers crossed. I know that's not going to sit well with them either. So I think using a pressor to me makes sense. But the evidence to do it is actually surprisingly not there.
Well, paradoxically, you're just raising the blood pressure, which you're really just doing tissue perfusion. If anything, you're reducing that.
So this is another counter argument. So his counter argument was, you're raising the blood pressure, but what is that actually doing to tissue perfusion, et cetera? And that's another counter argument. But I don't think we're ever going to see that study where we're randomizing people to just sit there with blood pressures of 60. Well, yeah, I like the way this guy thinks. Like, screw you, buddy. They came in with sepsis, now you're totally screwed. So,
Maybe a study of 5 liters of fluid initially on versus leave.
well, I definitely like the idea of that. So the question there was, what about a study where instead of relying on pressors, like if you have 2 liters of fluid, unresponsive, just keep going strong with fluids as long as they're not, like blowing up like a balloon or something. I really like the idea of that. I think we all have a lot of clinical experience doing that. And my clinical experience says that is better because that is going to help more with tissue perfusion than this artificial raising of a number, which doesn't really have, I think, that much of an impact on sort of the cellular level. So is there a study about that? I haven't seen one, but I like the idea of, I don't want to do one either, but. So again, it's part of the guideline, but the question was, is there a study showing that works better than pressors? And I don't think there is one. But I mean, the guidelines say keep giving fluids until you get their CVP over 8, right? That's what the guidelines say. So repeat boluses are encouraged. Okay, that's it. I'm done. Thank you.